Cast is now starting. All attendees are in listen-only mode.
Well, welcome. How you doing there, Rich? Good evening.
I'm doing well, thank you. Thank you guys for joining us on a beautiful, warm Tuesday night here in South Texas. Guy, I don't know how it is there, but man, it's hot here. I'm every time, I get towards the end of July and I'm thinking, God, why don't we go on vacation somewhere in Canada or Alaska or something?
Well, that's where I went. I don't know if you went. We went for a few weeks, and it was really nice. It's nice here. I just got back from a bike ride, so I think I'm done sweating, so we can get started on talking about devices. And Rich, you and I have been doing this for pushing 20 years each, and I know we've done thousands of devices, and I know we've probably had hundreds of hours of discussions about devices. When we developed our device selector, we talked about them, and it's hard to do an hour webinar where we're going to talk about devices in an hour or 55 minutes, because I think last time I checked, Rich, was 150, 200, something like that, FDA cleared devices. So there's a lot out there. We've tried most of them.
Look at that picture there, Guy. I mean, we could talk for an hour about every single one of those devices. And like you said, we've tried most of them. I've made quite a few on myself. I know some of you are just getting started, and that's a great way to do it. Just make a couple on yourself, and your staff and your staff's husband or spouse or whatever. A lot of those people snore. So we certainly want to get you started, and we want to give you some pointers about, what I like to say, guys, you can't make a wrong device, but you can make a better device. And that's what we're going to try to help you do tonight.
And we're going to cover the ones that we do the most in our practice today, 2018, July 24th, the day before my son's birthday tomorrow, so I can remember the date. And so, which one's the best one to do? And Rich and I came up with a system that works, like you said, most of the time. We might be able to do a better device, but we came up with a system, and he and I mapped this out, and we came up with this. We measured this all off in our lab, and we just took pictures, and we just put the different devices up there. And some of you have heard our not so great jokes in the past, but we're kidding, but we're serious. If you literally just picked a device and you rolled the dice or threw a dart at it, most devices would work in most situations, but we might pick one that's a little bit better, like Rich said. So I think the thing that we see the most are dentists are afraid to get started. They think they've got to have some big sign from above to get started, and you've got to have all the stars aligned perfectly. And what if I make the wrong device? If it doesn't fit well, or if it's not comfortable, or we think we want to try a different one, then do a different one. Just get started doing it. Don't let this stress you. We're going to help you tonight. Don't think we're going to dodge the bullet here and not tell you what we think. But the bottom line is just get started doing it.
I agree. Get started. Do it. Just do it. We borrow the Nike slogan, I guess, without getting sued. Yeah. Just do it. So, these came out a while ago, Guy, and we talked about the practice parameters, and this was a big deal back when we got started, because, when Guy and I started this, everybody was like, well, do the dental devices work? And that, it's not a question of that anymore. The parameters came out in 2006, and they came out again in 2015. And basically, they're pretty much saying, hey, these things can work. We should be using them.
That's right. And I think our next webinar coming up, some of you are experienced out there. A lot of people attend these webinars are somewhat new to dental sleep. So it's been about a year or more since we've done really the basics of dental sleep, why you should be involved, who it affects, what the prevalence of it is, models for doing this. So if you just think, I really want to get involved in this, well, today's great. You can learn about the devices, get started making those on yourself, your team members, and then tune in a few weeks on August 7th. And today's the day that we'll get you understanding why this is important. If you're not doing a lot of dental sleep in your practice, you're really missing the boat on helping your patients, helping yourself, and helping your teams do an enjoyable and profitable service. So we'll talk about that next time. Here we are, Rich. I just changed the slide because you've been doing this 20 years. I've been doing it, pushing that. Well, gosh, that's a lot, man. I'm old all of a sudden.
You didn't change the slide. You still got that good-looking picture of you there. So.
Well, that's a few years ago.
What did you fix one of your misspellings?
No, I changed yours to 20 here. It said 15 there. I think we had an old slide there. So, I mean, we've been doing this for a long time. Rich and I have been friends and partners for over 10 years now, and I think we don't know everything, but we've done thousands of devices, and we try to our goal each day is to get up and help dentists do this in their offices. That's our mission. If you attend tonight, you will get an email with CE. So if I don't stress out if it's not immediately there, but it will be there. If you don't see it, check your junk folder. And so this is what we do, Rich. I mean, I have to say, the day we met 10 or so years ago, it changed our lives. But I think it didn't just change our lives; it changed nearly well, we have thousands of people that use our system, dentists and dental office team members. And I think I'm proud about what we do. And what we do is we help dentists who want to succeed in dental sleep, who want to treat their patients. We help them with education, coaching, software, and support into what we call the 4 pillars, which are screening, testing, and treating and billing your patients. So if you need help with that, let us know. Just type in consult. We're going to answer all the questions as they come through. We have our whole team, our member support team. We have a whole room full of dental sleep experts that go to work every day to help dentists with their challenges. They're going to be helping answering these questions. Type your questions in the consult and the questions box, and we will answer them. But if we can't get to it tonight and you want to know more, you have some specific challenges, then just type in consultation and we can talk to you about how we can help you. And we'll actually answer your challenges first and give you some valuable insight. And then we can also tell you about how we can help you in your practices. So one of the ways we help these courses too, and the courses we do all over the country, doing one in week from Friday in Melville, New York, and you can see some other dates coming up: St. Louis, Cleveland, Orlando, Rochester. And we do a truly practical, hands-on course. You get a dental device on yourself or a team member. You get a sleep test on yourself or a team member. It's a 2-day course where we get to actually make realigners for the patient, for yourselves. We take bites, and the course is $9.95, including a dentist and a team member. And if you type in course tonight, you get $200 off. And I mean, that's the best deal going in dental sleep. And we'll put the slide up at the end. Rich, do you have your topic?
That's the best way to get diagnosed and treated for sleep apnea, by the way, too. That's about 1/5 of the cost of what it costs you to do in your own hometown, not to mention all the education that you get. So, yeah, we've done this meeting 2 years in a row now, and this will be our 3rd year. Great lineup of speakers. Everybody you talk to says, man, it's the best dental sleep meeting I've ever been to, because it's practical information. It's every speaker will get up there, and when they talk, they're going to talk about something that you can take back to your practice next week and actually implement and do. And I'll pretend like I didn't hear your question, Guy, about what I'm talking about, because no, I haven't figured it out yet. So,
yeah,
it'll be something good, though, I promise you.
Yeah, I'm going to be talking about lowering when people's AHI doesn't quite get as low as we'd like, but basically how you do successful treatment. And if you tune into further webinars that we'll do in the future, as well as to come to one of our courses, this is what we teach: the steps of dental sleep medicine. And if you can just find systems for each of these, we can help you learn those systems, and in 45 minutes or less of dentist time, you can successfully treat a patient from start to finish. On average, I mean, there's patients that take longer, obviously, but this used to take us a lot longer, and we can really help you make this a fun and profitable part of your practice. All right, we can go over some of that in a little while. Today, we're going to be talking about one of the treatment parts of dental sleep, in particular, which device to use. And I've borrowed this slide from my good friend Alan Moses years ago, and still use it, that I show that what happens when our patients fall asleep at night. And this is what happens to the airway, and in particular, the airway just closes. And as you all know, this causes a lot of problems. I think back to Rich's point, you can make a better device. Does it really matter how we tighten that airway up, with what springs or hooks or pieces of acrylic that we do that with? If we just get that airway open just that much more, it's going to make a huge difference, right? And
it matters that much more, which one we use. So, Guy, we hear dentists all the time. They freak out about, which one I should make. Just make one. All of the devices we're going to talk about tonight will work. We're going to try to help you get those little tiny differences this one might work a little better in this particular instance. But you got to get over that. What do you think it is, Guy? I'm not sure it's fear. It's maybe that as a dentist, we have that, do no harm. We don't want to hurt people. And I'm just telling you, you're going to help people when you do this, and if you figure out something and you thought, well, maybe this device will work a little better, ask the patient for a couple $100 to help you with the lab fee and make them a different one. I do that occasionally still, Guy, even to this day. So.
Yeah, and one of the best advices you gave me when I first met you is you said, just go out and make 5 devices on one of your team members, and then make the next one, and just make the next one. And even if you just go through these 5 or 6 devices we're going to go through tonight, and just do 1 or 2 on someone, and then do the next one, and don't even overthink it. You're going to learn so much from that process, way more than we could teach you in 55, 60 minutes tonight. And the whole thing is getting started. I think we've hammered that, but it really is the biggest obstacle. All the stuff we're going to teach you is irrelevant if you don't have the ambition to go get started. So let's get going. Medicare. We did a billing webinar a few back. Rich and I used
that was pretty popular, wasn't it?
Yeah,
everybody wants to know about Medicare, but you got to use certain devices.
Right.
And here's your list. It's not very long. There are some that are being added to this, but these are the ones that we think you should consider at this point.
Yeah, and we kind of divide those into the Herps and then to the tap, and because there's different iterations of both of those. And the good news about this, I'm not thrilled that some of these other devices, some of the dorsal designs like the Prosomnus, is not covered by Medicare because of some silly maybe rules that they have. But the good news is that most patients can be treated with either one of these, and certainly between the 2 of them. It's rare that you can't treat a patient with one of these 2 devices, because they're really quite different devices. And I'm glad at least we have some choices. The Herps is probably the one that has the most iterations and types out there, wouldn't you say, Rich?
Yeah, a lot of labs make these, and Guy, I don't think I've seen a lab or a device that I didn't like yet. The one on the right there is made by Whole U because it's got a metal substructure to it, and I have to say they made me one of those, Guy, and I like it because it's so thin.
Yeah, because of the metal.
Make it awful thin with the metal, but you do, like you said, there are different iterations of this, and the arm itself, some of them have 1 screw, 2 screws, some of them go here or there, and that kind of thing, and some of them have dots and pluses. So they're little iterations that you have to pay attention to, but I don't know, Guy, when 5 minutes you can learn all that stuff, right? When you get it, you start playing around with it.
Yeah, and Steve Carsonson, I teach with down to Pankey, he labeled this one kind of the universal device. And I think if you're going to start with a device, most cases, if they're missing some teeth, and some things we're going to go through with you, it's rare that this device just won't, it's just contraindicated. And so it's a good one to start with. I would say what you just said, there's a lot of options with it in different labs to do, but let's just talk about the basic principle maybe first, Rich, and then we can go into the pros and cons. The basic principle is you have arms, no matter which iteration you have, and then you have a mechanism to advance the lower jaw. Most of them use what we call these barrels, and you can see on the left side, you can see it on the screen, right, Rich?
Yes, I can see you moving your mouse.
Yeah. So you put a little screw instrument in here, and you move it towards this plus, and when you do that, it moves that barrel back, which protrudes the jaw. And as Rich mentioned, you can see on this Whole U one, they've got a little arrow here. That's so because that little plus is really hard to see, especially when you're over 50, like I am, and you got to get the readers out. You can see that to turn that. And some of them have these 2 barrels, so you turn the one, and then you kind of snug it down against the other one to keep it from possibly vibrating and loose. So each of those are different. They're maybe a 1/4 to 1/8 of a millimeter each time you move them back, and that's the concept behind it, whether they come in acrylic or metal or what have you. And some of them even have the adjustment back here on the upper, and it adjusts a little different. That's the one by Somnomed. So that's the basic premise of the Herps. And again, you may see one that looks a lot different. So here's where we like them for, though. A lot more on the more than less, it looks like.
Yeah, my biggest thing with the Herps, Guy, because remember, when we talk about Medicare, Guy, I like what you said earlier. It's basically the tap devices and the Herps types of devices. And I think that's a good way to look at a lot of patients, because you'll notice that the more and less, a lot of what we talk about. So on the more side, with the tap, we're adjusting from the front. That's the one with the screw in the middle. With the Herps, we're now to the side. So it kind of intuitively makes sense to me, Guy, that if I can't breathe through my nose as well and my tongue's a little bit bigger, that I would want to take that mechanism from here to the side. Now you can still treat people with big tongues, you know, and can't breathe through their nose as well with a tap, but this might be one of those instances where we talk about it might be a little bit better to do this, you know. So that's why I just think about, if you get any takeaway from this, big tongues, can't breathe through their nose as well, you know, that's a great pro side for the Herps.
Yeah, and let's talk about why that is. The Herps allows you to open your mouth. And I wear a dental device every night myself, and I have nasal problems, if you can see in the camera. I've broken a elbow and a fist or two with my nose over the years, so it doesn't function as well as I'd like it to. And so if you can't breathe through your nose and you have something that locks your mouth shut, it's claustrophobic to nasal breathers. Even if you can kind of get air around the side, it's claustrophobic. So devices that allow you to open are a little less claustrophobic overall. So if you got a patient who's really claustrophobic, being able to open up and swallow, it just makes you feel a little bit more.
Makes a big difference, and we don't want to understate that. That can be a big deal.
Because why do our devices work better than CPAP many times? Because you wear them. You know, CPAP works, but you've got to wear it. And we've got to go back to that. If the patient's real apprehensive and they're claustrophobic, and we're going to show you the tap in a little bit, and if they can't wear that for some reason, then it's useless if they can't wear it. So know your patients a little bit. Here's the better device thing we're talking about. Being able to open makes it less claustrophobic. The other thing is we're going to be talking about a dorsal design coming up. Similar, you can open your mouth. What else happens here when your mouth allows to open? The device can fit looser, because if the device locks you into place and your mouth wants to drop open, what happens, Rich? You pop out of the device. So it's, you know, if you've got one of these devices that rigidly holds you together, and then your mouth does want to drop open, then you pop out of the device, and now the device isn't functioning because you're popping out of it. So these devices can actually fit looser in general, right?
Sure, because I can move a little bit. You know, I'm not locked in.
And I'm not pulling.
Now I can move. Now we can add elastics, and we can do rubber bands, and we can do some things like that. Those are little tricks that Guy will probably talk about. I don't want to steal your thunder, Guy, for getting that AHI down a little bit more, but that might be a trick that would make it work a little bit better. But like you said, you cannot underestimate that feeling of claustrophobia. Or I do that. You know what I think of, Guy? I can wear a tap and I do okay, but what bothers me the most is I can't do this right here.
Uh-huh.
I never realized how much I like to lick my lips until I, wore a tap. So, little things like that. I don't suggest that you put that into the patient's head before you give that to them.
Very good point.
Yeah, because you don't want to talk about the negatives. We always talk about the positives. Are you ready to start sleeping better? You want to feel better. You want to get rid of that brain fog. You want to do this. There's a reason that when people come to my office and they sit down, most people get a dental device. Mm-hmm. And a lot of that just has to do with the positives, and talk about the positives, and we'll deal with the negatives in that side of that. Question I have for you, Guy, about this: when you put minimal teeth on there, what do you mean by that? Let's say I don't have as many teeth. What do you mean by that? And what is minimal?
Yeah, well, it's minimal's minimal. It's a gray area. But the reason we have minimal teeth on there is this doesn't have to fit as tightly. We can even do this on a completely edentulous upper that works fairly well, because as the patient opens, it'll still keep their jaw forward. But if it has to snap real tight, when their jaw wants to drop down, they pop out of the device and the jaw falls back. So this device can fit very loosely. I've done it, Rich, with no posterior teeth, and it just sits on the ridge like a partial, and it works fairly well. Now, if you add those elastics, well, now it's getting a little more complicated. It's got to fit a little tighter. Why would we add the elastics? Well, the negative to the mouth opening, at some point, that can cause the airway to be compromised. They don't work as well. We do better if we breathe through our noses. We're meant to breathe through our noses. And if we can maybe address allergy, address structural problems like I have, and get them breathing through their noses, and we put those rubber bands on there, and that kind of encourages them to breathe through their noses, sometimes that'll make this device go from not working so well to working fantastic. So I always recommend on any device that allows the mouth to open to have the ability to add elastics or some way to encourage them to stay closed. And then you want to get you a set of 2 or 3 lengths of rubber bands and different rigidities, and just have them on the office and play with it till you find, you know, the least sturdy one that'll kind of help keep their mouth closed. If you get them too tight, you're going to run into the problem of maybe the device popping loose, especially if you did it on that person with minimal teeth. I know we're spending a fair amount of time on this subject, but you're going to see as we talk about the other devices, these concepts of mouth opening,
they
elastics,
apply to all the devices.
They apply to all the devices. So we want you to get the concept down, not just Yatros and Drake said, use this device on this particular patient. We want to kind of have you understand the reasoning behind that. So I think we said a lot about it. The severe bruxers, I don't want to say it doesn't work. If we go back a slide, and if you've got a severe bruxer and you do this one, I'm feeling pretty good about it. Because they can, you know, but these devices can break. It can break right where it goes into the acrylic, but these are adhered to the metal. If you got a severe bruxer and you want to do the whole Respire all metal framework, then I would take that off the left side and move it over there. Your traditional acrylic ones, I just saw one just 2 days ago that were just cracked out on a patient, but it does allow them to move, which is nice. So. Anything else on these, Rich?
No, we put aesthetics down there, and my answer to that always, Guy, is turn the light off. You know?
And let's address that too. You know, this metal kind of freaks people out. It kind of makes a little bit of noise. And I think what you need to do once you get going is a really good way to do this is do these devices on yourself, and now you have a study model to show your patient. And as long as the patient holds it in their hand and says, yeah, that looks good to me, then you're not going to have any aesthetic problems. But if you show that to them and go, oh my God, I don't want all that metal in my mouth, it may make you gravitate towards an all acrylic one, as long as insurance and everything lines up to do that.
And the other thing I will say, Guy, is when somebody goes, I don't know, that metal's intimidating. I said, bite your teeth together real hard and feel that big old huge muscle you have on the side of your cheek. Uh-huh. That's why I want that metal in there. Because I'm afraid you're going to tear something else up, and it kind of changes their mindset from, hey, it's a bad thing, to, oh, hey, that's a good thing. Again, we try to stay on the positive.
And I think on this subject, before we go to the next device, is the way I like to do this, and I know Rich does the same. We go through the exam and we talk to our patients, and we say at the end, here's the device I think you should have, and here's the reasons. I don't say, here's 6 devices, pick one, unless you've got more time than I do in your life. And they're going to pick the wrong one, first of all. So not that there is really a wrong one. So guide them towards that when they go, well, the metal. You know who's wearing this device? One of my most difficult patients in my 30 years of being a dentist, both restoratively and as far as a mandibular advancement device, my mother. And she's you've met her, Rich. She's I love my mother to death, but she's she can be difficult at times, and she's doing well. She's like, oh, I'm going to wear all that metal, and she's wearing it every night now. So, all right, I think we've talked about the Herps enough, and again, a lot of that was about concepts. So the tap, it's a little different, isn't it?
It is. Now we're pulling from the front instead of kind of pushing from the side, and this, you see the DreamTap here. Do we have a picture of the latest iteration? I go all the way back, Guy, to the Tap 1. It used to have a little thing that stuck out, where you turned the screw and stuff like that. But then they went to the Tap 2, then the Tap T, then the Tap 3, then the Tap 3 Elite, and now the DreamTap. So the 2 that you can get now are the DreamTap, which was the previous picture, and this one here, which is the Tap 3 Elite. They are both Medicare approved. Both of those are. One of them, the plate's on the top, the other one, the plate's on the bottom. So it's a little bit confusing. But again, like Guy said, I love your idea, Guy, there of make one on yourself. And now you actually have a study model with the device on it that you can actually use. But, I learned from Keith Thornton, Guy, years ago, a fellow Texan, and we like to stick together with our guns and all that stuff. And, he has been so involved in research, Guy. I mean, when you look at the amount of research that's done on this device, it's just overwhelming. And there's so many documented cases of treating very severe patients with this. I don't know for sure, and we don't want to talk bad about the other devices, but something about pulling from the front does seem to make a difference in most of the studies when we look at that. You know, again, we're mostly hitting in the front, so it kind of acts like an anterior discluding element. But if my jaw gets a little off one way or the other, we can add posterior stops and we can tripod it, you know, and we do that. And basically that screw is infinitely adjustable. You know, you have 3 different hook sizes that this comes in, and then we always count half turns. I'm not sure why we've always done that, Guy. Do you guys count half turns also?
Yeah, I think everybody I know does half turns. Yeah.
Yeah, so we always count
180 degrees.
180 degrees when we do that. So, you know, that's why I put on here on the more side the severe disease part of that. So, you know, if somebody comes in with an AHI of 80 and they desat to 59% and they spend, you know, 30% of the night below 90%, I'm immediately thinking tap. And sometimes that overrides the stuff on the right of that where it's less. You know, if they remember, we talked about before, like you said, Guy, these are the concepts we want to get through. So with people with big tongues and they can't breathe through their noses well, we remember we had that on the positive for the Herps. Well, we have that on the negative side for the tap on this. So again, you got to use your brain and you got to think about it, you know, when we do this.
Just in case it's not clear, because some of you have maybe are not seen this, you have a little key that you put. It's a little hex wrench into the front. It doesn't matter if it's this one or the DreamTap. They both work the same, except you just turn it the opposite direction. And that just moves the hook forward or backwards. And it, as Rich said, pulls the jaw. Each 180 degree of that key is about a 1/4 millimeter. I'm with Rich, and you know what, Rich? I've asked at least 3 or 4 other dentists that I know that's done in the 1,000+ devices, and I asked them, what if you had to pick one device out, you had a severe case, and you had a severe case for $1 million, who gets the AHI the lowest, which one would you pick? And everyone I've talked to have said the tap for that particular reason. And we all just have our little biases, but it seems to be a recurring theme. If we think it's going to, it just does a great job. The other reason I like it is we can titrate it in the sleep lab. If the patient needs to go into the sleep lab and they're severe and we want to know how else is working, they can actually adjust that themselves, or the technologist can go in and turn that without taking the device out of the mouth, because you can just put the key in and turn it and then put the key back down. All the other ones you're pretty much going to have to take out of the mouth to make any adjustments on a nightly titration. So I think we've covered it fairly well. There's different iterations. Yep.
Let me make a comment about the Bruxers, though, and the fewer teeth, too, Guy. Remember on the Herps, we talked about we can make it with no teeth on the top and just a few teeth on the bottom. We can't do that with a tap because we've got that. Remember, now I can't. Guy did a real good talk about the claustrophobia part where I can open my mouth. Well, now I can't do that. Now I feel locked in. And that really does freak some people out. So, you know, it's just a conversation you have to have before. I put on the Bruxers, Guy, the more side, simply because I do believe that the anterior only position does act a little bit like an anterior discluding element. And I think if you give a Bruxer something flat in the back to bite on, I think he's going to bite on it most of the time.
Well, at the very least, he's going to put more force because it's closer to the hinge. So I totally agree with that. Absolutely.
Yeah, just the simple physics of that, you know, make it a little bit more. So again, these are concepts, don't you think, Guy, that every dentist out there knows and understands? You just have to kind of apply them to what we're doing with a sleep device.
And back to the fewer teeth. Now, I've done this on canine to canine before, or first premolar to first premolar. So you got to use your brains a little bit, as Rich has always told me over the years. And you know, if the teeth are just in the front, well, maybe it'll work if they're good teeth. And last thing I think on this, this is probably the biggest contraindication of a device. If someone's really claustrophobic, that's one. But the other is, if you've got a big, am I in front of the camera there? If you've got a big deep bite like that. And so just to get the edges of the teeth to where they're edge to edge, you may have to open a deep bite up 9 millimeters. Now that whole hook, that's 9, 8, 7, 8, 9 millimeters, depending on which one you use. You may have to open them up to 18, 19 millimeters on a deep bite. And so you probably want to go to a thinner device on someone who's a deep bite. So that's probably one of the few, I wouldn't say it's an absolute contraindication, but certainly something you should be aware of if someone has a really big deep bite.
Well, it certainly is on somebody when you say, how far can you open your mouth, guy, and they can open their mouth that far.
Right.
You know, and,
Oh, yeah.
and they're class 2 with a deep bite. So
Right.
again, that's where you got to use your brain. You know, I think when you're sitting down there and you're going through your mind and you're talking with the patient and you're doing this and you're trying to figure out what the best device is, I don't think it hurts to think out loud.
Uh-huh.
You know, I tell dentists to do that all the time, Guy, because it lets the patient know that I'm thinking about which device would work best. And as I do that, and I go, okay, well, let's think about this. If your bite's like this, and then we add that and we do that, and you can't open quite as far. That's why I don't like this one as much in that particular case. I think patients like that because they like to know that you're thinking about this and you're thinking about them. You're not, you know, that I'm thinking about you who are sitting right here in front of me right now. And I think that helps.
Yeah, help, especially as they know they see an ad on TV where they can go, you know, get one of these bowl and bite devices. This is part of why we add value to what we do. All right, the EMA. You know, I would say this is probably the most underestimated device out there. It's so simple that we think, well, how can that be worth anything here? You know, considering we're going to be charging these people whatever for our treatment. Understand most of what we charge our patient isn't for this piece of acrylic. It's for our guidance through this treatment process. It's for our skill and expertise in our brains that we're using and our judgment. So that's what you get paid for as a doctor, not your hands like you do in dentistry. And so this device works by having some kind of like Invisalign trays with Visacryl, I think it's made out of, and you can get them with some different materials, but for the most part they're made with this material. And then we have Biocryl.
Right.
Biocryl said the wrong thing. Thank you. You have different links and different rigidity bands that you put on here. Typically, they just put these hooks on the canine and first lower molar area, which is roughly about 21 millimeters on an average adult. And so when you look at the bands that we have, 21 millimeters is the longest, 13 is the shortest, and then this is the least rigid to the most rigid. And just to make this easier for you, I typically live in the blue area here, maybe the yellow. If someone's really stretching these things out, I might go to clear. I hardly ever use the white in the definitive end, maybe at the beginning, getting used to it, because these stretch out too much. These are really a real tough job to get on, and these blues kind of are the best mix of what you want. And these are 1 millimeter increments, so you just line it up and decide how far forward you want and put the appropriate one on. There is a little indentation. The key there is remembering that the number goes towards the cheek because there's a little relief area around, which my picture doesn't grab very well here, to allow for that little button, we call it, to go over it. Anything else to add on how those work, Rich? And we can talk about the pros and cons.
That's good. I think what you're going to find is this is very similar to the Herps, right? Because our adjustment's now on the outside again.
Mm-hmm. It's on the outside. It's actually much smaller than the Herps, except for the metal one like you got from Whole U. It allows the mouth to open some, not quite as much as the Herps does, because those rubber bands have a limit. They usually put little pads. I don't know if you can see that, but actually the default design is they put little lower pads to kind of open the bite up a little bit to allow room for the tongue. And these things work well. The biggest problem with these, I would say, it's probably the least of the durable of the devices. That being said, I've seen them that are 8 or 10 years old, so don't say that they don't they don't last. They certainly can. Make sure when you tell your patients, the number one thing is not to pull on those buttons. Don't use these as insertion and removal tools. That'll break those off. If they'll get their finger back here underneath the edge, that'll make these last twice as long. And I think that one of the big challenges here is we only have so much flexibility with these bands. So if someone's really class 2, you know, they've got a 11 millimeter over bite, and we may put that 21 band on, and they may be about as far forward as they jaw can possibly go with just that 21 band. So really big time class 2 in particular, maybe class 3. For class 2 people, that could be a contraindication. be one where it might be difficult to get used to. And the other one, if you have the regular suck down type material and the teeth are real diverging, have you ever had these, Rich, where it's like, man, I can't get that seated, can't get it seated. Oh, it's seated, now it's loose because the teeth are all going over which direction, and it's a little harder to get around those undercuts because this material doesn't have quite as much flexibility as some of the others. What are those?
Yeah, that's the snaggle tooth that we have in there. You know, when you got a lot of undercuts, if you just think about, go back to dental school and your little survey thing, where you survey 20 thousandths of an undercut. And, on a normal tooth, that's close to the gum line where this device would then do that. On somebody that's real, got really malopposed teeth and all that line comes up very high on the tooth now, and everything below that has to be blocked out. So like Guy said, it doesn't flex quite as much. So again, that's where the contraindication. The other thing I'll say, Guy, go back one slide. So when we talk about the class 3, we talk about that button being on the upper canine. So the upper jaw doesn't move, of course. So as you shorten the rubber band, you're going to pull the jaw forward. That's the best way for you to remember that, because sometimes you have to think about that. But if I'm already in a class 3 relationship, pretty soon I'm just pulling up and down. I'm not actually pulling the jaw forward. So the class 2 is the longest rubber band. I'm too far forward already. And then class 3, I can't go far enough because now I'm up and down. So again, you got to use your brain when you think about that.
And communicating that with the lab so they just don't do the standard put the button on the canine and first molar can help in those situations as well. But you still have a limitation to how far. And I think the other limitation is I don't know if I've ever used these 13s. You certainly aren't going to be able to use this one very often. It's really hard to get those little short ones over those buttons. So you really only have maybe 5 or 6 links here that are easily usable.
Use a lot of.
Right. Yeah.
And
so
we usually, Guy, we'll give people like 2 of the yellow 20s and 2 of the blue 20s, and then 2 of the yellow 19s and 2 of the blue 19s. So we'll tell them use the yellow, then the blue, yellow, then the blue. It's almost like the white is too soft and the clear is too firm. So like the guy said, we usually live in that yellow and blue area. Now, if you get somebody, I will say, Guy, if you start somebody on a 21, blue, for example, and they're like, man, my jaw kind of hurts or something like that, you could go to a 21 white.
Right.
And it gives them a little more, mobility, and they're like, hey, I like that, but like I said, they wear out a lot faster. So,
and what happens, they'll get stretched out and then it won't work as well. So what I do here's one thing I think it's one of the big advantages to this device. Well, one of them is there's no metal in it, and sometimes that's important for some patients. But the other is when I'm finished and the patient, let's say we end up with an 18 blue and they're happy with it, that I will typically give them 6 pair of those. So, whatever.
And we'll see in a year for your annual.
We'll see in a year. And so every 2 months, I want you to change these out because they'll get stretched out. Now, what happens is a lot of these patients are so happy, they don't want to come back for their annual recall. And they call me up we call them, they don't come in. Then 14 months later, I want some more bands. Well, you need to come in for your annual recall before we can give those to you. And so I have a much higher success on recall for these patients because of that. So other thing I like this for too, I think, I don't know if it's poor oral hygiene. I mean, as much as we want to think we can change those habits, there's not as many metal holes and craters to get junked up here as you do on some of these other devices. All right, dorsal. We got to get going, make sure we're finished on time here. Dorsal, Rich, this is probably one of my bias. I'm more one of my favorite ones to do. If it was Medicare approved, I would do it on a lot more patients as well. Unfortunately, it's not, and that's a whole nother subject. But it's the one I wear most nights myself as some form of the dorsal, and there's a whole lot of different kinds of dorsals out there.
Yeah, some of them have the wings, in different places and the screws. And, that interestingly, Guy, we're not here to talk about compliance chips, but on the bottom left there on that particular dorsal, we can now put chips in there that you can download. We're doing these, I'm going to say, Guy, 1 or 2 a week now we're doing in my office where we're putting these compliance chips in and we're reading that. But, the adjustment part is the jack screw. That's the same jack screw we use in dentistry. So if you think about that middle one where you see that yellow arrow going down, and we turn that screw, that jack screw, that front part of that moves on that jack screw, which of course is pushing on the wing, which is pushing your jaw forward. So that's how these work. And when we go to the pros and cons of these.
Yeah, I want to mention on the whole U, it's a little
Okay.
different. It moves the wing back,
Right.
but it does the same thing. There's a little bit of an advantage because the wing stays still and the jaw moves, but they basically all work the same. You have a little instrument in there. You turn it. It's just about 1/10 of a millimeter typically, and they work identically the same. Some of them, the wing moves. Some of them, the piece of acrylic moves it forward. So, there's even one we're going to talk about here in a moment. The Prosomnus, they have a typical traditional dorsal design, but then they also have one where they just fabricate, because this is a milled device or a CAD/CAM milled device, they don't have any adjustments as far as metal goes. What they do is they just reposition these wings. So you put this one in and you want to move another millimeter forward, well, you put a whole new tray in where it's configured differently. And one real nice thing about that is that's a really dense piece of acrylic that it's milled out of, and so it's a little sturdier. So you can get these any way you want them. I mean, you can say I want 1 millimeter apart, 0.5 millimeter apart, and you can usually get them with 4 to start with, or you get them with 6, or they even have an unlimited way of doing this. But in other words, if you have a 0 and a 1, and then you go to a 2 and a 1, well, that's moved it 2 more millimeters. And then you could turn around and put a 2 with the 2, and now it's another 2. And it just depends on how you mix and match these, and it's all where those arms are. And again, what's nice about it, there's no moving mechanism on this. There's nothing for the patient to turn. And that's actually, Rich, personally, the one I've been wearing every night recently is this Prosomnus IA design, because it's really small and thin. It can be made a lot smaller, and I like that because I'm a mouth breather and I can get a little more air through my mouth.
Yeah, and you can get them with the anterior discluting in there. You can get them with the anterior opening. You can get all that kind of stuff. You just mark that down on the lab script.
Right.
But these are a lot the same as the EMA and the Herps as well. Where we do I love the tap. I make a lot of taps. We talked about that. But when I get real big tongues and I get the disease isn't quite as severe and nasal patency is an issue, like you said, Guy, the dorsal is probably the most comfortable device. If you made somebody in your office all 5 of the devices we're talking about tonight, and they got to wear each one for a month, a lot of them would say the dorsal is probably more comfortable. And part of that is, because we don't have to make it as tight. It doesn't have to fit as tight. I have the ability to move, like
you can
Guy
put it
said,
in 2 pieces. You can put it in uppers. Yeah. A lot of the other ones are all one piece. So, and
sometimes the people have very small openings in their mouth. They can't get one that actually has to be hooked together before you get it in there. So again, these are a lot of the same principles. Can't breathe through the nose as well, big tongues, mouth breathers. I don't have quite as many teeth. These things work good. Why? Because they're not hooked together. I can open and close a little bit, and I don't have to worry about it coming out. I think my favorite dorsal that I wear, Guy, I can take my tongue and just flip it out. That's how loose it is. Yep. But I've learned to kind of keep my mouth shut, while we do that. When we put on there deep bites, again, deep bites are difficult to treat because, like Guy said, when you have a real deep bite like that, I have to open this far and then I have to do that. So remember what the lab wants from these things when you do this is they want 4 millimeters of opening in the back, not in the front. So you have to use your brain. You have to look at the curve of speed. You have to look at, all of these things. So when
we can get away with 3 with this one because it's that milled device. So for your deep bite, the Prosomnus IA is really a great choice because it can be made very thin and it's still yet sturdy because it's a jet mold. I mean, I don't know all the details of the acrylic, but it's not a salt and pepper acrylic. It's a milled acrylic, and it's stronger, and it can be made thinner. You don't have to have the room for the mechanism here too on the cheek, so it's just a very small device for that. Right? Okay. The other thing on this too, they can break back here, and this can be bulky with some of the traditional ones. And so if you have a coronoid process that's tilted in, that's really tight back there, you may want to do the prosomnus version of this, or maybe the whole U where that wings on the bottom. It's a little less bulky right there, because those I've run into a problem just on a rare occasion when someone's really tight back in there.
Or even the EMA, you know, because we have a button here and there. We don't have anything back there except
Right.
a little piece of the device. Again, these are all little tricks we're trying to give you that just make a difference.
Right. So now, if you've been listening to our webinars over the years, there was a device called the Narval that has been out. We've done lots of those. They recently quit distributing those in the U.S., but the good news is we have a very similar device. It's called the Panthera, and this is a 3D printed device. And I think the overall one on this is, Rich, it's the strongest device that I've used. Now, the record is I've only done a handful of the Pantheras because they're kind of new to the market. I've been using the other brand, but it's a similar technology, similar material. And I've had patients who've really broken everything, and this technology can be made very thin, and it just holds up. And you can get these anyway. I was a little confused with the lab script the first few I did, so I want to make sure you understand. You can really get it in 3 ways. You can get it posterior occlusion, anterior open, for the people you really want to give that mouth breathing, you know, the nose nasal congestion, mouth open person. You can have it hit just in the anterior, you know, premolar to premolar. I'm sorry, just in the anterior, or you can hit it, have it hit pretty much full occlusion. Yeah, to like first molar to first molar are your choices there. The only thing I've noticed with these different, because I've done a handful of these, different than the Narval, if you've done those, is they won't actually, and we're working with them on this, they kind of block out the anterior teeth. So if you want something that really tightly grabs those anterior teeth, they currently don't offer that. But other than that, it's very similar to the Narval if you've ever done them. These rods are a little sturdier actually than the Narval, which I like better. They come in 0.5 millimeter increments. You can basically just open this device up and they pop right out, and you can put different links on this. And they've
got quite a range of motion on those as well.
Absolutely.
Don't think I?
Yeah, they have a huge range of motion. These fit well. I mean, they're very thin. I mean, back to the thin. This is probably one of the thinnest devices you can make for that person who has a deep bite, and they're very sturdy. I think for the person who I think they're going to break this, or maybe they already broke one, and we're redoing it for some reason, this is what I'm going to go with. Negative is it's on the higher cost of the devices out there. And I don't like these if the patient's going to have dental work done, because you can't add acrylic to these. You can remove material, but you really can't adjust these. You can't, if you make too much adjustment, they're not going to fit anymore, and you can't, use your own dental lab to make this thing work well. So if they have pending dental work, I'm just not going to do these. You still there, Rich? I see your camera turned off. There you are.
Yeah, I just had to scratch my nose. So
okay.
Good.
Anything else on that? I think
no, and the cost, is not that big an issue. Sometimes it is. I'm in network with United Healthcare, and they just don't pay me that much. We've said for years, Guy, that at $1,500, remember, think back to one of those first slides Guy had up there, where I love that slide, Guy. We have that little guy walk up the stairs, It's 45 minutes of the dentist's time. I mean, how much would you have to make for 45 minutes of your time? That does take some staff time and do that. But again, most of you good dentists out there have learned to delegate stuff, so you're doing that. And in that particular instance, with an in-network lower cost, I don't even bring that one out.
Right.
I mean, now we might be talking about the EMA, which is probably a third of the cost. But again, we can't talk good enough about all of these devices we made. We want you to know we like them all, and we think they have certain indications, for where you can use them and where they might be better.
Right. Now, most of these devices are acrylic. Then there's some that are metal, and some are like the Panthera. But if we're going to use one of the all acrylic devices, what touches the teeth? You really have 3 choices that we typically choose from. There's other ways of doing this, but typically we have all acrylic. So it can just be acrylic through and through. And the advantage to that, when you're talking to your lab, is that you're familiar with acrylic. You can grind on it, you can adjust that you can add to it. You can get just all acrylic where the undercuts are built into the acrylic, or you can have ball clasp that you can adjust. And the advantage too is you can make this sometimes a little thinner because you don't have to have room for the acrylic and the liner. The second material I think that's most popular is, I think the two most popular are all acrylic with or without clasp, or this what I call flex material. Some labs call it comfort fit. They have a lot of different words for it, but it's that rubbery kind of gaskety material that you can literally, it's spongy when you push on it. And the advantage to that is a little more comfortable for the patients. I think they just like it a little bit better from the get-go. It can go around those undercuts nicely if you have diverging teeth. The negative is it's harder to adjust, and I think we lose a little bit of control over the forces on the teeth, and it could lead to maybe more tooth movement that we're not in control of because of that. And I think the material can sometimes delaminate and discolor, and depending on which labs and how old it is. Any other on those two materials, Rich?
No, that's good. It is a little more comfortable, the all acrylic. And again, I don't give patients a choice on this, guy. I'm looking at it and I'm thinking, okay, what would work the best? I can tell you that if you got really, really short teeth, that's the next material I'm probably sure you're going to talk about, with the thermocryl. But I think the hardest part in my office, guy, all day, every day, day in and day out, is too tight or too loose.
Right.
That's probably the biggest challenge that we deal with in my office. And we make a bunch of these devices every day. We're doing this all day, every day. So the acrylic, what I love about the acrylic is I can grind on it and I can add to it, and I can almost always make it fit. Remember, with the flex material, if it's too tight and I get too aggressive and I grind too much, now it's too loose.
Right.
I can't add to it.
Add to it.
Yeah. So,
and you know what? When it comes to the comfort on that, I think it is more comfortable, and I use it on really picky patients. In general, I don't use it that often because I don't think a patient's going to really notice. They only notice the difference if you gave them two appliances. They'd say, oh, I like this one better. But they would get used to the hard acrylic, and I'd rather have the hard acrylic. And this thermacryl, what it is, it's a heat-sensitive acrylic that basically, and there's different words for it, AccuFit, different companies call it different things. But basically, you can heat it up, and it gets soft, and then as it cools, it gets hard again. And so if we want it to fit tighter, we heat it up, let it sit in the mouth, and get it in those undercuts and cool in those undercuts longer, tease it in and out a little bit, and now it's tighter. If we want it looser, we tease it in and out more. And there's a little bit of a learning curve to it. But as Rich said, you can always make it fit tighter, always make it fit looser. And if someone has a crown or filling or even a bridge sometimes, we can refit this thermacryl around it. So I love that. And if we're having trouble getting good impressions, it works quite well for that as well. I think we already talked about the nylon and metal material. Rich and I spent a lot of time talking about this over the years, and what we did is we looked at these factors on which device we might do on a particular case. And if for our DS3 members, you have an option of using this device selector, and you can go in and slide these little things back. If they're a big-time bruxer, you can move it this way. If it's comfort's the most important, or the bite is real deep or shallow, and you hit the sort button, then it'll put you in the ballpark. But what I think is really, Rich, I think was that this has become the most valuable for is as we take our members through the learning process, I have them use this as kind of a quiz. It kind of teaches them how to think about this so that, they can use these factors into making decisions that are important to understand the concepts. Because you know what? They're going to have a new device tomorrow. I was on the phone at 5 o'clock today with someone who's invented a new device, and I wanted to bend our ear about it a little bit, which sounds promising. So, if we learn the concepts, you're going to be able to do this better in your practices than it's just, hey, this device works better here or there.
Yeah, because I like that, guy. It's almost like a little checklist for the things that you need to do to evaluate which device might be best for that patient.
Yeah,
and that's what we've been trying to talk about tonight.
Yeah, we're getting a lot of questions. We're going to get to them all. If you have specific questions and you want us to spend some time with you, again, type in consult or consultation. One of our trainers will get on the phone with you. We'll talk about what issues you have and help you if any dental sleep issues that we can help you with, or questions, or just wanting to know what the next steps are, and we can tell you how we can do that. There's some side effects from this I also want to mention the public service announcement. That's my dog and that's my device. The number one reason I see breakage of these devices is this right here. And we tell every patient to keep these away from the dogs because they will destroy them. And the labs are smart enough to know when that happens. I've tried to slip those back into the labs and say, hey, I think this broke and you need to fix it. And they usually can tell that the dog got a hold of it. So don't try that. They know better. You need to have a way to get the jaw repositioned, but for time reasons, Rich, I want to make sure we get to any questions at the end. But when we're finished with this, we want to make sure we get their jaw repositioned. I think I'd like to talk about at least these 3 goals and then move on to any questions that we have. When we hand someone a device, we don't just say, here's good luck to you. I mean, if you want to be successful, this is probably as important or more important than which device to use. Wouldn't you agree, Rich?
I mean, if you're not going to wear it,
right.
I mean, none of the rest of it makes any difference.
Doesn't make any difference. And I think having that expectation of the patient, look, I'm going to give you this device. You may feel better. You may love me the next day. You may hate me the next day because you can't sleep because you got something new, or you may feel the same. Okay, and I'm always right because it's one of those 3. It's either the same, worse, or better, right? So give them that expectation. But I just want you to wear it and get used to it for a few weeks. Once you're used to it, we're going to look at your symptoms, and we're going to see what your reasons, your chief complaints were. We're going to be doing a webinar in the future about treatment steps, and we can talk to you about more specifics, but we track their symptoms, and we see how we're doing, and then eventually we're going to do a follow-up test through the different processes that we do. So are you wearing the device? No. Well, then we need to figure out why not. Usually it's something's too tight or too loose, or they're having a little sore spot. If they are wearing the device, then we ask them about those symptoms. And if their symptoms aren't better, then we're going to adjust the device some more. I know this is real high level, but we can talk about how many times you turn it, but you've got to tune into the future webinars or come to one of our hands-on course to really get down to the nitty-gritty. We adjust it more, and then we ask them that same question. When we're all finished, we're going to say, look, your symptoms are better. We need to make sure that your airway's open enough that you're at low health risk from this problem airway that you have, and we're going to make some further adjustments based on your test. Now, how do we help you do that? This is what I want to get to, is we help you track that in DS3. Before, what I used to do, Rich, when I first saw my patients, how's the device doing? Fine. Mm-hmm. Yeah, I gave it to you a couple of weeks ago. How you doing? Okay. How do you feel? All right. Are you better? Maybe. I don't know. What's better? Did you ever have that game years ago when you first started doing this?
You learn which questions to ask, and that's part of how we developed this software guy too, was to try to guide you through that. So we go right through. Are you wearing it? How many nights out of 7? 7. Oh, fantastic. You get an A+. Give me a high five. Snoring, better, same, or worse?
Right.
Your energy levels, your sleep quality, how many times you get up. We just walk right through this thing. It's like a template for how we do that. So now I've got this running record of where the device was and how they're doing and when are they ready for a sleep test. We've tried to design this to really help you become a better practitioner and how you do it.
Once you understand what you're looking for, we can take a glance and we can see, hey, their snoring went from a 12 to a 4 on the Thornton snoring, or from a 9 to 3 on the 0 to 10 scale. And we can at a glance know if they're better. Now we can say, hey, Rich, or Mr. Doe, as the case is, looks like your snoring is a little better. It went from a 9 to a 3. Do you feel like, oh, yeah, come to think of it, is better? Well, then we can move on to a sleep test. And if we do multiple night sleep tests, and those of you who don't know what AHI, that's okay. 30 is not good. That's 30 times an hour someone's not breathing well. And if we have a way and system to test them on multiple nights, we can at a glance can see, well, 30 went down to 6. This is what we want to do. Or maybe we can stop at 8 if that's good enough. And we can teach you on where you need to stop and why. But what we've done is we've made a system that allows at a glance you to do this. Before I had this system, Rich, this would be about 12 pages of paper I had to look through to try to make a clinical decision, which is what you're getting paid for when it comes to dental sleep. So that's just kind of a glimpse of what we'll talk about in some of the upcoming webinars as we walk you through these steps from the screening your patients to getting them tested to now we're going to get them a consultation and talk about whether they're good candidates, to doing impressions, delivering their devices, and then follow up both symptoms and testing. And again, this can be done in under an hour of dentist time easily with systems that we can teach you, and you can make a fair amount of money doing this. Hopefully that's not your only reason. Hopefully you want to help your patients. But if you do, a device every other month, it's going to add over $8,000 to your income, even after you pay DS3, after you pay a conservative lab fee of $350, and even if you pay someone else to do your billing. And if you're doing one of these a week, it can add pushing 6 figures to your dental practice, which in most dental practices, that's a substantial difference. From nearly $90,000 it can add to your bottom line, because all the expenses are coming out of this. And I don't think we're playing with numbers here, are we, Rich? I mean, that's very conservative.
I don't think it's unreasonable at all that if you get involved in this and you do it well. And again, when you look at what you're paying us, we are the best bang for the buck out there, period. Nobody helps you do this as much as we do.
And one device a week? I mean, 1 in 5 adults has this problem. That's not too aggressive, is it?
I don't think so.
Yeah.
Very reasonable. Guy, I think we've gotten to pretty much all the questions. I've been looking at them. Our team's been doing a great job of doing that. What are we doing? What are we talking about next?
So I think, if we back up to this slide for a moment, if you want to see how this can be a reality, 1 in 5 adults has this problem in your practice. 9 out of 10 don't know they have it. So next time we're going to be talking about why dental sleep is important, how many patients in your practice have it, how do you get involved, what's the first steps, and why should you be involved? And it's kind of going back to the basics of why I think all dentists should be at least screening their patients, and why most of you should be at least treating some of your patients in your practice. So going back to the basics, next time, August 7th, we hope to see you there. Again, if you want to know more, we're truly the only organization out there that has a 360-degree solution for this. We either directly provide or we have partners that plug in to help you provide dental sleep services to your clients, your patients rather. And it's very reasonable what we do that for. Don't go recreate the wheel. We've created it. We're continuing to recreate it or to create it because things change. Big changes in insurance billing just this month in Medicare that we're navigating and letting our members know about. And it's to do that on your own is difficult. So if you want to know more, type in consult. We'll be happy to sit down and talk to you about how we can help you, and even have a really inexpensive. We have an introductory offer that's under $1,000 for 3 months, around $1,000 for 3 months of our services that someone can talk to you about. And this is free, so hey, we even give them free things away here today, Rich. Last week came out this latest edition of the Insider.
I think it's about the 24th or 25th edition, something like that. So we've been doing this a long time. Again, it's just full of lots of practical stuff. We get industry leading experts and all kinds of different topics in there and all kinds of different things. And it's an online digital magazine. We like the green idea of all of that. We're not something that we're printing or doing anything. So it's free, just sign up and you'll get it in your inbox, and it's something you can read sitting on your back porch.
Yep, and it's a lot of information. Again, it's guaranteed to be sold out of rooms for this symposium. We sold out of rooms last year. We're probably going to sell the whole symposium out this year because we're really way ahead of where we were the year before. So if you want a really great day and a half in sunny Florida in February at the Hilton in Clearwater, we promise it'll be well worth your time. It's very reasonable. $500, $495 for a dentist to come to that, and a room block. I think it's $250 a night for the Hilton in February, which is their normal rate, so almost double that, I think. So if you want to come, make sure you get registered early. You got to be registered for the symposium before they give you the room block. But the rooms will definitely be gone. And I'm saying that as much because last year we had a lot of people calling, why can't I get those rooms anymore? Make sure you sign up now. Here's how you get a hold of us. If you have any questions, certainly we're there. That's what we do. And Rich, you said the questions. I haven't looked at them because I'm, of course, too busy talking.
No, I think it's good. We covered a lot of different things. You guys read through that thread. There's a couple of labs we found out about we didn't know. So we always learn something from these things too. When you look at that. Somebody had a question, Guy, about how long does a dental device last, and that's a great question. We tell people on average, about 2.5, 3 years. I've seen them last less, and I saw a little old lady had an EMA. That's the one with the rubber band on the side. And the guy said, it doesn't look like it will last, but it can be deceptive. It was 10 years old, guy. She'd been wearing it every day. She swore she didn't miss a day in 10 years. So part of that depends on how much they clench and brux on it and all that kind of stuff. But, on average, we tell people about 3 years, and we do everything we can to make them last as long as we can.
Yeah,
I think that's it. I don't see anything else.
Okay, and I think having a policy, whatever it is, I mean, that's your policy. Most insurances, some will pay 5, some will pay 2, some will pay 3, but having a policy in your office so that when the patient comes in saying, here's what we do, here's how much you're paying me, and here's how,
this is what you get for that.
Right, and sometimes we eat it if they break it, and if they lose it or the dog gets a hold of it, that's not on us. But having a policy is the most important thing, and I think you can expect most of them to last near 5 years, except for the ones that you don't, that hopefully you can look at their masters and figure that out. I'm not always, they don't always come in telling you they're going to break them, but most of them last that length of time. So, yeah, we got to most of them then. All right, well then, I think, I haven't had dinner. I'm ready to go eat something. What about you? Does that sound good?
Thanks again, Guy, for putting that PowerPoint together. It looks great. Thanks to our team for answering all those questions. And thank you guys all for joining us tonight. We appreciate it very much.
Thanks for taking your evenings. All right. Good night, everybody. Bye-bye.